You're listening to the Inspired Mom MD's podcast. I'm your host, Dr. Cindy Van Prague. I help physician moms take back control of their time and energy so they can prioritize what matters most and thrive at work and home. In each episode, I bring honest conversations, inspiring stories, and practical strategies, including interviews with incredible women who are redefining success on their own terms. Let's dive in. Hello, everyone, and thank you for coming back to the Inspired Mom MD's podcast. Something's been on my mind about heart disease lately, and it does remain the leading cause of death for women, yet so many women don't think about their heart health until there's a problem. And sometimes the very things that we dismiss as women as normal or just part of our busy life or getting older is something that maybe is worth paying attention to. Today's guest is Dr. Sindhu Koshy, a board-certified cardiologist with more than 20 years of experience and a special focus on women's cardiovascular health. She is a Menopause Society certified practitioner, bringing expertise in how hormonal changes during midlife can influence heart health and long-term cardiovascular risk. In addition to caring for patients, Dr. Koshi is a passionate advocate for women's heart health and is frequently featured in national media, helping women better understand the risks, symptoms, and opportunities for prevention that are often overlooked. Welcome, Dr. Koshi, to the podcast.
Thank you so much.
I am so excited to have you here. So I'm an anesthesiologist, as most listeners know, and I just have a special place in my heart for cardiologists. Sometimes I wish I had one right next to me in the operating room when I see something that's a little different. I'm like, oh my gosh, what is that? Which doesn't happen often, but man, you guys are amazing. So
Thank you.
I totally admire your expertise. I would love to start with your story. So if you'd like to jump in, why medicine? Why become a doctor? And then how did that lead you to cardiology and women's heart health?
So, why medicine? I actually don't even have an answer for that. My mom says starting at 4 years old, I said I was going to be a doctor. So, clearly, my pediatrician was like amazing because I don't have medical people in my family. And my mom actually gave me a book recently that I had written in kindergarten. And in it, I had written about the author, I'm going to be a doctor one day. So, I mean, it was set in stone. So I don't know why. I mean, there was no other reason. Cardiology, however, I was going to be a pediatrician. That's what I thought I was going to do. And then in my first year of med school, my father ended up needing bypass surgery, which then, since I was the only medical person in the family, everybody was coming to me to ask questions. And at that time, I was in my first year of medical school, so I knew nothing. But as I did more and more research trying to figure out my father's own health, that became like my interest, and I ended up loving cardiology.
And then you went a step further and got certified in menopause and have a special affinity for women's heart health too. So how did you get down that lane?
Yeah, so I think just women and heart health, as soon as I started my cardiology career, I became more passionate about it. Cardiology is a world where there's a lot of men in the specialty. I mean, only 12% of cardiologists in this country are women, and of that, only 3% interventional. So I would always hear the midlife woman coming in with symptoms and kind of being blown off even by male mentors. It's just anxiety, it's just this. Or if they ended up having cardiac disease, like a heart attack or a stroke or something like that, then we were saying things like, it was just bad luck, but nobody was looking at like the risk factors and the fact that she was young. And then as I went through my career, we'd always learned that, cardiovascular disease occurs late in women. And we kind of expected it like in an 80-year-old woman. Like that's when you were seeing it. Grandma was going to come in with her heart attack. But that's not what I was seeing in the last 15 years. Most of the women I see that have their first heart attack are between 40 and 65, which eventually, as I also started getting a little older, it kind of clicked. I'm like, wait, there's only one thing that happens at this time. And so as I started focusing more on that, cardiologists in general are taught no hormone therapy. Like that is like against our laws. We don't do that. And so I felt like it was really a disservice as more and more women were coming complaining of their cardiac symptoms. And really, the first cardiac symptoms or the first symptoms of menopause and perimenopause are actually cardiac. Your resting heart rate rises and you have palpitations. That's even before your hot flashes. And so I was like, this is all cardiac. And so that kind of drove my interest. And, you know, when I became researching about menopause myself, I was like, gosh, I should just become certified because I now have my own expertise in this in a completely different aspect, which is the cardiology realm.
Yeah, and I hear women say, "Oh, my heart's racing," or "Oh, they feel these things," and they brush it off because it's just their age or perimenopause or menopause. But you're actually picked up on that with your background and said,
Yeah.
"No, there's something here. We need to look into this a little
Yep.
deeper." Yeah. Okay. One of the things I find fascinating is that women don't really think about their own heart health or maybe even other parts of their health until there is a problem. And I'd love to talk about some of the risk factors that women may not realize actually matter. And what should we as women be paying attention to long before the bigger obvious, maybe obvious symptoms appear? So, what are some of those overlooked risk factors that you're seeing?
The traditional risk factors are, of course, if you're a diabetic, which in our world, we really include those pre-diabetics and borderline diabetics. I mean, it's pretty black or white. You either have it or you don't. And I know we look for that magic number of your hemoglobin A1C, but things are already happening in your heart once you're pre-diabetic. High blood pressure, high cholesterol, but the things that women that are very specific to women are things in pregnancy. So pre-eclampsia, if you had preeclampsia in your pregnancy, your risk of having your first heart attack is typically 10 years after that pregnancy. There's like a
Okay.
20 to 40% chance of having a heart attack 10 years later, which means if you were 31 and had a child, and had preeclampsia, at 41, you could be having your first heart attack, gestational hypertension or gestational diabetes. We know those are risks for diabetes and hypertension later, but any of those definitely are things that I recommend if you have those that you should be seeing a cardiologist every year, at least once, just to go through the risk assessment once you were diagnosed with those things in pregnancy. You
Mhm.
still consider pregnancy as the biggest stress test. Like, there's nothing bigger than that. So if you didn't make it through a pregnancy without some kind of a complication, you just failed a stress test as far as we're concerned, right? So
Mhm.
those are kind of the ones that are women specific. But once we hit that age of perimenopause, which is 10 years before menopause, so we'll say late 30s, we should be looking at things like your cholesterol and your blood pressure because they do start to rise. And a lot of times, women and their providers will kind of brush things off as, yeah, your number's getting a little higher, but we'll just kind of keep an eye on it.
Yeah.
Let's wait 6 months, let's wait a year. And a lot of women don't want to start doing risk reduction with medications right away. Whereas I feel that if it was their husband and they're in that office and I say, your husband's cholesterol is high and I want to start this medicine, the spouse is definitely the one to be like, yep, I will not only help him start the medicine, I will put it in his pillbox and I will likely feed it to him.
Mhm.
But for women, there's such a boundary where we're like, well, maybe not just yet. And I'm not sure. I have these 10 other things planned. So I don't know if I want to work on this. But this is like, we take care of everybody else first. And I feel like that in itself is its own risk factor.
Oh, that's a
And
good
then
point.
lastly, it's the menopause. If you went into menopause early, and so let's say you had surgical menopause, you had to have your ovaries removed for some reason, let's say cancer or something else, where you were young in your 30s and 40s, that puts you at the highest risk for a cardiac event. So that,
Mm.
or menopause before the age of 40 naturally puts you at a higher risk for cardiac disease.
Mm. So what I'm hearing is going back a couple of minutes, if a woman, even if she's 25 and experienced some complications during pregnancy, 10 years later, that's 35. So
Yep.
we're talking really, really young women. Are they
Yes.
already being screened? How do we get the word out to women, OB-GYN? I mean, maybe they're already doing it. That's me being naive.
So the part of the issue I always say is women typically We see a pediatrician, and in 1819 we graduate. Often between college and pregnancy, our only doctor for women is our gynecologist. That's it. We go in for our pap smears, and then we get pregnant, and then we see them for pregnancy. And then somewhere between like our last pregnancy and 50 years old, women only see their gynecologist once a year for their annual, which doesn't often include a full physical. And sometimes, your gynecologist may order things like lipids, knowing that they're your only doctor, but often we don't have an internist. So definitely, I think more and more gynecologists are aware that these are risks, but it often is like a gynecologist trying to refer you to a cardiologist. It is a difficult thing because the patient is not, why are we going? I was just pregnant. Why would I be seeing a cardiologist? And I do feel like women need to be seeing an internist or family practitioner, someone that can kind of look at their whole risk assessment. They don't always have to see the cardiologist, but at least someone is managing their risk further than what a gynecology has the expertise in doing. But I do feel that gynecologists are definitely checking lipids, checking blood pressure. They're doing all of those things because they know they are usually a woman's only doctor. Our gynecologist is the one person that we probably see our entire lives, compared to any other doctor that we have. So getting the word out and really getting the word out to women that these are things to keep in the back of their mind, that just because I'm not a diabetic, but if I had pre-eclampsia, like this puts me at a higher risk.
And you're empowering the women and the patients so they can ask their doctor and start a conversation completely. And that's why you're here today too.
Yes, absolutely.
So I think that many women assume that they would recognize an issue in themselves. It's just you recognize in your partner, oh, I'll know it when it happens. But the symptoms in women can look very different than what we traditionally hear about for men. And on top of that, women are conditioned to dismiss or explain away symptoms or just push through. So, what are some of these symptoms or signs that women commonly brush off, in your opinion, that may be different from what you would see in a man?
So, I mean, firstly, most women expect that they won't have cardiac disease until they're in their 70s or 80s. So, there's like this lack of expectation that it could happen when I'm 47 years old, where we think about men having their first cardiac about 45. Like women start asking for their spouses to see a cardiologist for a baseline at approximately 45 years old, but we don't do that first. So, first is it doesn't matter how old you are. At this point, I tell women, if you have a heart, you're at risk. But the symptoms we see on television and everything, really the studies are done with men mostly, right? The women are not in a lot of these studies. So the expectation is you have chest pain at the top of your chest and it goes down your left arm. That is typically very true of men, but women don't usually have that symptom at all. It is like less than 10% of women that have that left arm pain and pain up in the chest. Most women experience their chest pain more in their epigastric or their stomach area. And so immediately assume that that is a stomach issue and not a heart issue. The studies have shown that women correlate pain with childbirth. So 10 out of 10, the worst pain of their life. Anything else, we've been conditioned to push through it. And a heart attack or a cardiac event, an acute event, is never, for a man or a woman, it is not a 10 out of 10 pain. Why God made this confusing, I don't understand, but it is typically like a 5 or a 6, or as I joke with my kids, and I know it's not on trend, it's like a 6, 7. Like that's it. They hate it when I say that, but that it's a good way to remember it. That's where it is. It's just an uncomfortable feeling. And women will, in the throes of an MI, a heart attack in the ER, when anybody asks them, tell me about your chest pain, a woman will always say, I'm not having chest pain. I never said chest pain. That's not what I said. It's just this pressure. It is this burning. It's this uncomfortable. It's discomfort. It is not pain. So I think people are looking, because we say chest pain, they're looking for pain. It's not, as far as I can tell from all the patients I've seen, it's not that bad. And so that is one of the things that we're kind of told to push through. Also, women don't get that left arm pain. They actually get it in both their shoulders or back between their shoulder blades, right where your bra hooks up. A lot of women say they have the symptom, they come home and they just want to take their bra off. Like it just feels tight, which I mean, don't we all experience that some days? And so the symptoms for us are a little bit more subtle. What's really interesting is women 2 to 3 weeks before their heart attack will have extreme fatigue. out of the ordinary. And I will tell you that every woman, and I probably would do the same, will find every reason for why I have that fatigue. We will justify it. Well, there was, it's Maycember, it's a million activities. There was graduation, there's, work, there was kid activities. And so I'm tired because I haven't had enough sleep. But a telltale sign is 2 to 3 weeks, you have extreme fatigue and then have a heart attack. And then shortness of breath is typically the symptom that women come in with. It's 50% of women have any chest symptom, but the rest of the women all have just shortness of breath, which is never normal. No matter how old you are, no matter what other issues you have, shortness of breath should never be considered a normal symptom for a woman.
Ooh. So that is a strong distinction.
Yeah.
Shortness of breath is. But man, these other symptoms just feel like such a gray area.
Yeah.
And I
It's so
too would just
subtle.
push through that.
Hmm.
Oh, so I'm imagining some women do get this overwhelming sense, or maybe not overwhelming, a slight sense that something's off, something's not
Yes.
right. So, how would you suggest that women advocate for themselves in a system that kind of brushes women off when they have that feeling? But yeah, you can easily talk yourself out of it.
Yes. So, in kind of the same as I said before, many women with a male partner who will come in like my husband would come in and say, I think I've got a hangnail on my left hand. We're going to the ER because it could be your heart. We just got to get this checked out. We do take care of everybody else first. For women, that what you said there is really important. That sixth sense, that women's intuition, if you feel like something is wrong, it's not urgent care, it's not your primary care visit. It really is the ER. And in the majority of ERs in this country, any symptom a woman has, belly button and up, is an MI until a heart attack, until proven otherwise. And all of those women get an EKG. And that's usually our first test. And it's a cheap, you get it in triage while you're in the waiting room in the ER, just to make sure that's not what we're missing. And the worst that it can happen is, guess what? This is just heartburn. It is not your heart attack, right? So, I mean, better to be safe than sorry. And it's never a bother. I always talk about, women will come in and they're having a heart attack and we're telling them you're having a heart. Well, I mean, it could have just been, I did lift up some heavy bags yesterday. No, ma'am, you are actually having it. Are you sure? I mean, we will justify and, and by the way, can we like take care of this at 3 o'clock? Because I do have to pick up my kids, right? I mean, this is all going on in our minds. But I always remind women, if we are doing all of that, we are taking care of everybody. If we are not there, guess what? They can't take care of themselves. It is not going to happen. So we have to take care of ourselves first. And that's a good example to teach our children. If you have children, is taking care of yourself is an important thing. We would do it for our children. We would
Mm,
rush them off to an ER, to a doctor for anything we thought that was worrisome. We need to treat ourselves the same way.
yeah. So advocating for ourselves means getting ourselves to the ER.
I really think that's what it is. It's us. I don't know that we be brushed off as often as we think, because like I said, belly buttoning up, any symptom, at least you'll get yourself
Yeah.
in the door. It's just us getting there. That
Yeah.
seems to be, and the number of women that will like rather go to the urgent care or call their primary for a visit because they're just not sure. But I think it's because we really feel like we're bothering somebody. And why we are either nurtured or our nature is that way, I really think it's a nurture thing. Like we as women shouldn't be a burden, shouldn't bother somebody, but they come in as, I'm sorry, but I'm having this. Why are we sorry about that? There is no man that says, I'm sorry, but I'm having chest pain. That doesn't
Mm,
happen.
this is just such a mindset shift for myself
Mhm.
because it was my own bias and assumption that, okay, if I get to the ER, they're going to brush me off. But really, it's myself making excuses. And
There's some kind of embarrassment almost. And I
yeah.
think it's really like, what if I'm wrong? Will they think I'm, not smart enough, or I'm, being silly or emotional, or is it
Hmm.
anxiety? But, the way I see it, women are typically late presenters, meaning they wait a lot longer than men to come in because
Hmm.
of these things. Like, let me first try the Tums. Let me just lay down for a bit. Let me wait 2 more days and not do anything and see if that helps before they show up. When you come in as a late presenter, it's already too late for us to help you. But I always say, if that was a man and, your husband walked in and said, I'm having this symptom, I'm not sure what it is, we are dragging them out of the house. Like it is a
Mhm.
guarantee that we're like, I am driving you or we're calling 911.
Yes, yes. So, if a woman wanted to take one step to really protect her heart health this year, what would you recommend she prioritize?
So I think the priority should be what I call knowing your numbers. And so not only going in for your annual physical and then let, your clinician, your provider, your cardiologist, your internist, your family practice physician say, everything looks good, see you next year. You now need to know what those numbers are. A physician is one thing, but we are the other part of it, right? So we have to partner with our physician to make sure that we are understanding what our risk is. So know your cholesterol, know what your goal is based on the risks that your doctor knows about you. And then how are we together going to get to the goal that we need to? Know your blood pressure. What is my goal? And how are we together going to get to that goal? And so knowing those numbers, knowing the blood sugar, unfortunately, knowing your weight, it is one of those things we have to know. You have to know what your weight is and know what your risks are and how are we going to work together to get to our goal weight if that's what's necessary. And so knowing some of that risk factors and knowing where we stand is really important. And I think making sure that we don't walk out blindly. Everything is
Mhm.
good is not a good enough answer, but that is
Mhm.
really up to us to be saying, what are my numbers and where should I be?
And what are the trends too? If you are seeing your doctor every year, what has been a slow trend? And is there
Yep.
something that's still good technically, but it's been going up? Or,
Yes. Yes.
yes, great advice. And know your numbers and then know which direction you're headed with your numbers
Yes.
too. And partner with your doctor.
Yeah. That's
Your
so
doctor is your
important.
friend.
Doctor is your friend, and I
Yeah.
always say, like, I don't want to be the parent scolding. Like, you're
Hmm.
not my child as a patient.
Yeah.
We're colleagues, we're working together for your health, right? I want to help you. And so we've got to work together.
Hmm. Hmm. So I'm hoping that the person listening today is feeling empowered, and I'm hearing hope that
Yeah.
women can get help sooner so that things don't advance to heart disease.
Yes.
So
Yes.
what gives you hope right now when it comes to women being more informed and empowered?
As I'm doing more of menopause and cardiology, I see women that are coming in to know what their cardiac risk is. I have tons of new patients, and they are women that are considering hormone therapy and have
Mhm.
menopausal symptoms, but they want to know, do they have cardiac disease? And it's just refreshing to know that they're 40 and 43 and 49 years old, and they're already asking what their risk is. It's wonderful. It's
Mhm.
also, we were just talking with another group earlier, and I was just saying how the American Heart Association has now added your menopause transition or menopause timing as a female specific risk factor to be discussing in a doctor visit. So, other than the traditional risk factors that we use in all of our risk calculators, like your cholesterol, your blood pressure, smoking, and your family history, timing of menopause is now recognized as a risk factor for women. So knowing that people now understand that women and men, although we have the same organ, they function differently and we have different disease and we have different risk factors is really important and gives me hope. And the fact that people want to hear what cardiac disease is in women. Just the fact that people want to hear it just tells me that people are interested in seeing that it's a little bit different.
Mhm. Mhm. Oh, I'm so excited to hear you say all of that.
Yeah.
Do you have any final words of wisdom for the listeners?
I really just want to say that don't forget that taking care of yourself is the most important thing you can do for your family and your loved ones. Because really, it is. If you're not there, you won't be there to help other people. And everybody wants to be there for you too. So don't forget that you are not like this sole little island. Everybody that you are helping, they want to be there for you as well. And so that should hopefully empower you to seek the help that you need and understand your risk and don't forget about knowing your family history, knowing what their risk is.
Mm-hmm. Thank you. Thank you for
Yeah.
that. How can people reach out to you?
So you can look for me, of course, on Instagram at SKoshiMD. That's one way, but I'm in a practice called Cardiovascular Consultants. We're in Michigan, and I see men and women, but have a focus on women's healthcare.
Perfect. I will put those in the show notes. And I thank you so much for being here today and sharing your wisdom and spreading the empowerment and the hope that we need to hear.
Thank you.
Thank you so much for tuning in today to the Inspired Mom MDs podcast. If this episode resonates with you, please share it with a friend who might benefit too. And I'd be so grateful if you left a review so other women can find me too. You can also connect with me on LinkedIn and explore free resources at inspiredmommds.com. And just a quick reminder, this podcast is for informational and educational purposes only and isn't a substitute for medical advice or care. I'm a board-certified physician, but this content isn't connected to my clinical practice, and no doctor-patient relationship is formed here. Please always talk to your own health professional about any mental or physical health concerns. And as always, take what helps and leave the rest. See inspiredmommds.com for full disclaimer.